Mark your calendars for RSNA 2024, Building Intelligent Connections. Join us in Chicago for the biggest week in radiology from December 1st through the 5th as we explore how to intentionally and intelligently build the right connections between people and technology, expand your network, elevate your skills, and navigate the changes shaping medical imaging. Registration opens July 17th. Go to rsna.org/annual meeting.
Welcome to the RSNA Radiographics Podcast. Today, we are talking to Doctors Santos, Schuch, Zapparoli, and Muglia from Brazil regarding their article entitled Practical Guide to Vi-RADS, MRI Protocols, Lesions, Characterization, and Pitfalls. Welcome to the podcast, everybody.
Thank you, Refky.
So let's start from the beginning. Why was Vi-RADS initiated?
So I can answer that, Refky. So basically, bladder cancer staging was the main driver of how treatment is chosen and the prognosis of a bladder cancer. And in fact, you have here a situation that is not so good as the TURBT. Usually you get biopsy from the lesion and the muscle layer or the bladder wall, trying to discriminate if there's muscle invasion or not, because this is fundamental for the staging and for treatment planning. And the question is, about 20% of times the pathologists don't get enough muscular tissue to decide if the tumor is muscle invasive or not. And sometimes there's a lot of proportion of false negative examinations for a muscle invasion. On the other side, you have the development of MRI sequence getting better with time. And previous to development of Vi-RADS, we have some systematic review showing nice diagnostic accuracy for detection of the invasion of the muscular property of the bladder. So that's the combination with promising technique MRI and gold standard, which was not so gold. So the biopsy in the TURB, the proportionated development of the Vi-RADS, basically.
So, Dr. Santos, what are the risk factors for bladder cancer?
Well, that's an interesting question. So it's important to remember that cumulative exposure to toxins significantly increases the risk of developing urothelial carcinoma. So elderly men are the most affected group because they tend to smoke more than women, and they are more prone to conditions that lead to urine stasis, such as benign prostatic hyperplasia. Additionally, advanced ages also results in prolonged exposure of the urothelium to harmful substances over time. So this group of patients has increased exposure to toxins, including tobacco tabolites, which are specifically the main risk factor for bladder cancer. Talking about numbers, tobacco smoking is the primary risk factor and is responsible for approximately 50% of cases, while occupational exposure to another chemicals is the second most significant risk factor, contributing to around 10% of cases. We can also list other risk factors, including chronic urothelial irritation or inflammation, which can occur in situations such as, for example, chronic infections, bladder stones, and also in patients with chronic indwelling bladder catheters.
Dr. Schuch, why is it essential to differentiate between non-muscular versus muscular invasive bladder cancer?
So, differentiating between non-muscle invasive and muscle invasive bladder cancer is essential because the prognosis and treatment strategies for these two conditions are significantly different. Non-muscle invasive is potentially curable, typically treated with intravesical therapies and regular surveillance, while muscle invasive bladder cancer often requires more aggressive treatments. Neoadjuvant therapy followed by radical cystectomy is the most common treatment of localized muscle-invasive bladder cancer. Accurate differentiation helps plan appropriate treatment, improve patients' outcomes, and reduce the risk of under or over treatment. Several scoring models exist to predict recurrence and progression based on clinical and pathology factors. Over time, up to 7% of patients with non-invasive blood cancer may experience recurrence, and the probability of disease progression from non-invasive to invasive to muscle invasive blood cancer can range from approximately 1% in low risk patients to 40% in high risk patients.
Dr. Zapparoli, can you talk to us about the limitations of TURBT and why MRI is helpful in the assessment of bladder cancer?
So transurethral resection of bladder tumor, or TURBT, has several limitations, but the most important to remember is that there is undersampling and understaging, leaving residual tumor in about 50% of patients after the initial resection, and this can lead to incorrect treatment and worse prognosis. There's also inflammatory changes that can delay the correct staging and treatment of patients. It's an invasive procedure with risk of bladder perforation, especially for deep muscle layer sampling. And also the procedure is operator dependent. And finally, there's also inter-observer variability among pathologists when it comes to assessing the muscle invasion. MRI, specifically multiparametric MRI, can help overcome these limitations by providing a non-invasive information about the extent of tumor invasion into the bladder wall and the risk of muscle invasion, anticipating the T-staging of bladder cancer.
So, Valdair, tell us, when should a bladder MRI be performed?
Well, I would start with the other side. So usually we don't use MRI for diagnosing urothelial cancer, which is usually based on the clinical symptom, which is a hematuria. And for that, CT urography or UroCT is the main indication. So bladder MRI should be performed for staging, was the primary indication or motivation of the Vi-RADS, is bladder staging. But beside that, lately we have some new indications for use MRI. So the first one is to decide between lesions that were called on by biopsy on first TURBT. There is a non-muscle invasion lesion, but we know that lesion has a high percentage of muscle invasion. So there is high risk for muscle invasion. For instance, lesions larger than 3 centimeters or high-grade urothelial lesions or multiple lesions, they carry on a high risk of muscle invasive disease. So you can use the MRI for trying to discriminate this patient, which is very good. And the last indication that I would emphasize is to evaluate the neoadjuvant therapy and trimodal therapy, which is becoming increased use for bladder cancer. So for evaluation of response assessment, you can also use bladder MRI.
Dr. Santos, I found it very interesting that you mentioned the difference between MR urography and bladder MRI. Can you explain to us the difference?
Absolutely, that's important. As Dr. Muglia has discussed, we need to remember that MR urography and bladder MRI are two different imaging modalities. Firstly, MRI urography provides a comprehensive evaluation of the entire urinary tract system, including the kidneys, ureters, and bladder. It usually involves fluid-sensed images, which means heavily T2-weighted sequences, and it also uses excretory T1-weighted images after IV gadolinium injection. So MR urography enables us to assess the entire urinary tract, usually in high-risk patients presenting with hematuria, which is the most common clinical manifestation of bladder cancer. On the other hand, multiparametric MRI, bladder MRI, specifically targets non-bladder tumors using a standardized classification system to assess the likelihood of the TRUSUR muscle invasion. So bladder MRI in this setting is typically used after a tumor has been identified, and it provides precise information on tumor staging. So we can accurately and non-invasively stratify patients into two different groups, those with non-muscle invasive versus those with muscle invasive bladder cancer.
Dr. Schuch, what sequences do you think are important in MRI and how should they be performed?
It is important to perform a multiparametric evaluation, which includes both morphological assessment with T2 weighted image and functional assessment with diffusion weighted imaging, DWI, and dynamic contrast enhanced, DCE. T2, called structural category, abbreviation SC, should be the initial focus of lesion assessment, primarily used for lesion detection, measurement, and localization, as well for defining the lesion's morphology. The WI helps to evaluating the cellularity of the tumor and detecting invasion into the muscle layer. DCE is essential for assessing the vascularity of the tumor and detecting enhanced patterns that indicate muscle invasion. Additionally, pre-contrast T1 weighted sequence with fat saturation is recommended to evaluate bladder hemorrhage and detect bone metastasis. These sequences should be performed in true axial and another orthogonal plane, usually sagittal, though coronal can also be used for T2, WI, and DWI sequences. For DCE acquisitions, the imaging should be performed in axial planes. This approach ensures comprehensive imaging of the bladder and accurate assessment of the tumor stent and invasion. All these images should encompass the bladder, proximal urethra, and lymph node stations. For male patients, the prostate and seminal vesicles should be also included, while for feminine patients, the uterus, ovaries, fallopian tubes, and vagina should be encompassed.
You mentioned performing the dynamic sequences. How long should the dynamic sequences be performed, Dr. Zapparoli?
So DCE sequences should be performed for 2 to 4 minutes. Typically, this can be achieved with 4 to 6 acquisitions every 30 seconds, but if possible, a high temporal resolution of less than 10 seconds should be used.
This question is for Dr. Muglia. Are there any limitations of bladder MRI? And do you think there are any areas within the bladder that might not be visualized on bladder MRI?
Yes, you know that for high quality interpretation, we need the exams with very good quality. And so for that, we need to adequate vesical distension. So the first one is get a really good image, which is based on follow the protocols indicated by, for instance, the Vi-RADS project. But there is some areas that we have to mention here. First, the areas with the bladder wall, which bladder wall is curved. The second, the trigonal, bladder trigonal, and the third one is the urethral meatus. So when you are dealing with lesions assessed on the areas of more intense curvilinear shape, so you have to look at all the sequence because these lesions could be tricky for interpretation. You know that trigonal, for several reasons, like the proximity to the prostate, can be very challenging. So lesions on these situations, usually the axial is not so good. So you need very good second plane for diffusion, like sagittal or even coronal. So that's a area of main limitation. And third one, usually for distinguish muscle invasion near the urethral meatus or the urethral vesical junction is really difficult. And here we'd like to say if there is a lesion near the urethra and you have hydronephrosis, it's sometimes you don't need to worry about if there is really a muscle invasion, because if there is hydronephrosis on this lesion, they usually is assumed by urologists as advanced disease. So basically these three areas are the main limitations in the bladder.
Dr. Santos, can you explain to us how the scoring system works for Vi-RADS and what is the dominant sequence?
So as discussed, bladder multiparametric MRI involves three main sequences. Firstly, T2 weighted images, also known as structural category, which is crucial for assessing the morphology of bladder tumors. And additionally, bladder MRI also includes two functional sequences, which are diffusion weighted imaging and dynamic contrast enhanced imaging. which provide insights into tumor cellularity and increased vascularity, respectively. So we evaluate the bladder tumor by assigning a score for each of these three categories based on different criteria, including morphologic features, which are better assessed on T2-weighted images, and also the presence or absence of a disruption of the muscular layer signal intensity, which is better assessed on functional sequences. So the final Vi-RADS score is based on different combinations of these three categories, ranging from 1 to 5, where muscle invasion is highly unlikely in Vi-RADS 1 and very likely in Vi-RADS 5. And we will dive into this scoring system later. So it's important to note that in cases of discrepancy between the structural category and functional sequences, the functional sequences should take precedence in downgrading or upgrading the tumor stage. In other words, the presence of muscular invasion is determined by functional sequences, with diffusion imaging being the dominant sequence for assessing this likelihood when optimal image quality is achieved.
Dr. Schuch, Dr. Santos mentioned the morphology of the lesion. Why is that important?
The morphology of the lesion is important because it provides a critical information about the tumor's characteristics, including the size, large or smaller than 1 centimeters, shape, location, and extent of invasion. It plays a crucial role in evaluating blood lesions, and certain morphologic aspects are essential for accurate assessment and appropriate categorization. Suspected bladder lesions can manifest in different forms, such as endophyte, exophyte, flat, and mixed forms. Endophyte lesions do not project into the bladder lumen and display only intramural growth. Flat lesions spread laterally across the bladder inner layer, leading the minimal distortion and thickening of the urinary bladder wall. Exophytic lesions exhibit endoluminal growth that protrudes into the bladder lumen. The growth patterns can be a papillary lesion with broad base, sessile, or pedunculate lesion. A pedunculate lesion is an endoluminal mass characterized by a stalk, which refers to a linear or curvilinear extension that connects the bladder tumor and to the bladder wall. Lesions with stalk are less likely to invade the muscular layer and generally have a better prognosis than without a stalk or sessile tumors. Furthermore, if there is a thickening of the inner layer, it can serve as a predictor of the muscular layer repairing.
Dr. Zapparoli, can you just briefly categorize how we can identify Vi-RADS 1 through 5?
Yes, of course. So for Vi-RADS 1, 2, and 3, it is important to note that the signal intensity of the muscle layer should be normal, especially on DWI and DCE, which are the dominant sequences, as Dr. Dos Santos has already explained. Differences between Vi-RADS 1, 2, and 3 lie in the size, the presence of a stalk, and the presence of a thickened inner layer. So in Vi-RADS 1, lesions are smaller than 1 centimeter and confined to the inner bladder layer. Muscle invasion is very unlikely in these cases. In Vi-RADS 2, lesions are larger than 1 centimeter and have to exhibit a stalk or a thickened inner layer, and muscle invasion is unlikely. In Vi-RADS 3, lesions are larger than 1 centimeter but lack the category 2 features of stalk or thickened inner layer, and muscle invasion is uncertain in those cases. For Vi-RADS 4 and 5, lesions show extension into the muscle layer on DWI or DCE, and the difference is the depth of invasion. So in Vi-RADS 4, lesions will show high signal intensity on DWI or contrast enhancement extending into the muscle layer, and in these cases, muscle invasion is likely. And in Vi-RADS 5, lesions extensively invade the muscle layer and possibly adjacent structures, with high signal intensity on DWI or contrast enhancement extending into the perivesical fat, and muscle invasion is then very likely.
That was a great summary. Dr. Muglia, has Vi-RADS been validated and what has been its performance?
Oh yes, definitely. Vi-RADS has been validated throughout the world. So you have studies come from all portions of the world, like Asia, Europe, Americas, Middle East. So I would like to divide this external validation in 2 points. First, the diagnostic accuracy. So the pulse sensitivity usually is around 80 to 93%, which is pretty good. And also specificity would be on the same range with slight variation. So diagnostic accuracy overall is really good. And the other point, it's about the question of reproducibility, which is pretty good for a young system like Vi-RADS. So the reproducibility using inter-class correlation coefficient usually runs or ranges from like 0.72 to 0.94, which is really, really good for a method which is supposed to be used largely. So there is good signs of external validation, but we do have some limitations that we need to do better. The first of all, some of the Vi-RADS 2 still have some muscular invasive disease. And the other point is that the Vi-RADS 3, it's usually a little different from other RADS, like RADS. So Vi-RADS 3, you usually more like the prostate Vi-RADS 3 because the diagnostic accuracy sometimes is compared when you use the Vi-RADS 3 as muscle invasive or if you only use Vi-RADS 4 and 5, but interpretation should be very objective based on the criteria that Dr. Zapparoli told us, but the conclusion or the assumption of which is best management, this could be variable according to the clinical scenario. For instance, if you have a situation that you know that the prevalence of muscular invasive disease is high, like you are doing bladder MRI after first TURBT, and you have a high risk lesion like is more than 3 centimeter or is multiple or is high grade lesion, you can use Vi-RADS 3 as the cutoff. So Vi-RADS 3 and up could be indicative of muscular invasive disease. So again, the interpretation is very objective based on the signs and criteria described here, but which you assume as the threshold can be variable at different scenarios.
So, Dr. Santos, are there any mimics of urothelial carcinoma on MRI that you can tell us?
Sure, that's interesting. Distinguishing urothelial carcinoma from its mimics on MRI is crucial. For example, post-contrast images are valuable for this task as they help us differentiate bladder tumors from non-malignant substances like blood clots or debris, which can resemble urothelial carcinoma on pre-contrast images. While these materials may exhibit high signal intensity on diffusion-weighted image, they do not demonstrate contrast enhancement. Additionally, focal or diffuse inflammatory changes often seen post-TURBT or intravesical treatments can mimic urothelial carcinoma on post-contrast images by causing either focal or diffuse early enhancement. In such cases, diffusion and ADC maps play a critical role in evaluating residual tumor tissue as they can assist us in distinguishing between inflammation and malignancy. Another important clue is the pattern of wall thickening. Some pathologies presenting with diffuse wall thickening are prone to be benign, while focal abnormalities may resemble malignancies on imaging, and cystoscopy with tissue sample are often necessary to confirm the diagnosis. In summary, we need to be prepared to distinguish urothelial carcinoma from its mimics. In some cases, it's challenging, and we may need to recommend cystoscopy evaluation to ensure accurate diagnosis and appropriate management.
Dr. Zapparoli, you briefly summarized Vi-RADS 1 through 5 category. Can you think of any instances when Vi-RADS cannot be used?
Yes, so there are instances where Vi-RADS cannot be used effectively. But the two most important to know is that Vi-RADS should not be used for non-urothelial tumors, such as mesenchymal lesions, for instance, as it is designed for urothelial carcinoma, as Dr. Dos Santos just mentioned. And it also should not be used in locations where the muscle layer is not present. The other instances where you should be cautious using Vi-RADS is in the post-treatment setting, as Dr. Dos Santos has already mentioned, and also in complex locations, as Dr. Muglia has already mentioned.
Interesting. What about bladder diverticulums? Can Vi-RADS be used for them, Dr. Schuch?
Bladder diverticular are typically acquired and characterized by an outpouching of the mucosa and lamina propria through the interruption of the muscle fibers, forming pseudo-diverticula due to the absence of the muscular layer in their walls. Bladder cancer originating inside the bladder diverticula is not assessed by T2 stage according to TNA classification. Consequently, Vi-RADS should be not used to assess the likelihood of muscle invasion in urothelial carcinoma inside the bladder diverticula, as it is designed specifically for the muscle invasion assessment. These lesions have a higher likelihood of being at a more advanced stage and invading the perivesical fat, like a T3 stage.
Well, thank you all very much. Thank you, Dr. Santos, Dr. Schuch, Dr. Zapparoli, and Dr. Muglia for discussing with us Vi-RADS. You can read the entire article in the March 2024 edition of the Radiographics Journal.
Thank you very much.
Thank
Thank
you
you,
very much.
everybody.
Thank you, my pleasure.